I want to tell you something about the cholesterol test that most people receive. The standard test that your doctor orders that comes back with four numbers and that is used to make decisions about whether you need medication. The number most people focus on, and the number most often discussed, is total cholesterol. And I want to be very direct with you. Total cholesterol is almost meaningless as a predictor of cardiovascular risk in isolation. There are people with a total cholesterol of 7 millimoles per liter who have a low cardiovascular risk. There are people with a total cholesterol of 4.5 who are at extremely high risk. The number alone tells you almost nothing, and yet it remains the number that most people know, most people worry about, and most conversations about cholesterol center on. I am not saying this to be contrarian. I am saying it because the science on lipids has advanced enormously in the past 20 years, and that science has fundamentally changed what we know about which measurements actually predict cardiovascular events, which particles cause arterial damage, and which patients benefit from treatment. The problem is that this updated understanding has not filtered through from research into routine clinical practice at the speed it should have. People are still being told their cholesterol is fine based on a test that is missing the most important information. And some people are being treated unnecessarily based on a number that overstates their risk. In 7 videos in this series, I have covered the liver, blood pressure, kidneys, diabetes, heart disease, and stroke. In every one of those videos, LDL cholesterol has appeared as a contributing risk factor, a driver of the atherosclerosis that underlies heart attacks and strokes, and a target for intervention. But I have not yet given cholesterol the dedicated, detailed treatment it deserves. That is what this video is. After years of clinical practice and reviewing the lipid literature extensively, I want to give you the clearest, most accurate, and most clinically useful explanation of cholesterol I know how to give. In this video, I'm going to explain exactly what cholesterol is and why your body needs it, including the fact that cholesterol is not the villain it has been made out to be. I will break down the different types of cholesterol particles and explain which ones actually cause damage and which are protective. I will tell you which tests to ask for, beyond the standard lipid panel, that give a genuinely accurate picture of your cardiovascular risk. I will cover the truth about statins, a subject surrounded by more misinformation than almost any other topic in medicine. And I will give you the dietary and lifestyle changes that move your lipid profile in the right direction. By the end of this video, you will understand your cholesterol better than most people who have been managing it for years. Let me start with something that I think changes the entire frame of this conversation. Cholesterol is not a poison that sneaks into your diet and clogs your arteries. Cholesterol is a molecule that your body produces, primarily in the liver, and that is essential to life. Without cholesterol, you cannot make cell membranes. Every single cell in your body uses cholesterol to maintain the structural integrity of its outer layer. Without cholesterol, you cannot produce steroid hormones. Testosterone, estrogen, progesterone, cortisol, all of which depend on cholesterol as their precursor. Without cholesterol, you cannot produce vitamin D from sunlight. Without cholesterol, you cannot make bile acids, which are essential for fat digestion. Your liver produces approximately 75% of the cholesterol in your body. Only 25% comes from diet. And when dietary cholesterol goes up, the liver compensates by producing less. The system is regulated. The reason cholesterol becomes a problem is not its existence, it is its transport. Cholesterol is a fat-soluble molecule and cannot travel freely in the bloodstream, which is water-based. To move around the body, cholesterol is packaged into carrier proteins called lipoproteins, particles that have a protein exterior and a lipid interior. These lipoproteins are what your blood test actually measures, and it is here, in the biology of lipoprotein transport, that the real story of cardiovascular risk begins. There are several types of lipoprotein. Very low-density lipoprotein, VLDL, is produced by the liver and carries triglycerides. As it delivers triglycerides to tissues, it becomes intermediate-density lipoprotein and then low-density lipoprotein, LDL. LDL carries cholesterol from the liver to peripheral tissues. High-density lipoprotein, HDL, collects cholesterol from tissues and arterial walls and returns it to the liver for processing, a process called reverse cholesterol transport. The ratio of these particles and the number and type of LDL particles specifically is what determines cardiovascular risk, not the total cholesterol headline number. The single most important clinical insight in modern lipidology is this. It is not the amount of cholesterol inside an LDL particle that causes arterial damage. It is the number of LDL particles circulating in the bloodstream, and specifically the number of small, dense LDL particles that can penetrate the arterial wall. Two people can have the same LDL cholesterol number, say 3.5 millimoles per liter, but one may have 3 times as many LDL particles as the other, with 3 times the atherogenic potential. Their standard lipid panel looks identical. Their actual cardiovascular risk is not. A standard lipid panel gives you 4 numbers: total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides. In most laboratories, LDL cholesterol is not directly measured. It is calculated using the Friedewald equation, which estimates LDL from total cholesterol, HDL, and triglycerides. This calculation becomes increasingly inaccurate at high triglyceride levels and at very low LDL levels, precisely the situations where accurate measurement matters most. Even when accurate, the LDL cholesterol number tells you the amount of cholesterol inside LDL particles, not the number of particles. As I just explained, this distinction is clinically critical. The problem with total cholesterol as a risk metric is precisely that it is total. It includes LDL, which is atherogenic, and HDL, which is cardioprotective, and VLDL. A person with a high total cholesterol driven primarily by high HDL may have an excellent cardiovascular risk profile. A person with a lower total cholesterol driven by low HDL and high LDL particle number may be at significant risk. Adding these together into a single number and presenting it as the primary indicator of cardiovascular health is, to put it plainly, an oversimplification that the current evidence does not support. The tests that give a more complete and accurate picture of cardiovascular lipid risk are the following. First, apolipoprotein B, ApoB. ApoB is a protein found on the surface of every atherogenic lipoprotein particle. Every VLDL, IDL, and LDL particle carries exactly one ApoB molecule. Measuring ApoB therefore directly counts the number of atherogenic particles in the bloodstream. Multiple large studies have confirmed that ApoB is a better predictor of cardiovascular events than LDL cholesterol, particularly in people with normal or low LDL cholesterol who nonetheless have a high particle count. ApoB should be the primary lipid target in cardiovascular risk management. It is available on most standard laboratory platforms. Ask for it by name. Second, lipoprotein A, written as LPA and pronounced lipoprotein a. LPA is an LDL-like particle with an additional protein called apolipoprotein A attached. It is a genetically determined cardiovascular risk factor. Its level is approximately 80 to 90% determined by genetics and is largely unresponsive to lifestyle intervention or standard cholesterol-lowering medication. Elevated LPA, defined as above 70 nanomoles per liter or above 30 milligrams per deciliter depending on the assay, is present in approximately 1 in 5 adults and doubles cardiovascular risk independently of LDL cholesterol. It is almost never measured in routine lipid panels. Specific treatments targeting LPA, including RNA-based therapies currently in late-stage clinical trials, are emerging. Every adult should know their LPA at least once. Third, triglycerides. Fasting triglycerides above 1.7 millimoles per liter are associated with increased cardiovascular risk, partly through their promotion of small, dense LDL formation and partly through their role as a marker of insulin resistance and metabolic syndrome. Very high triglycerides, above 10 millimoles per liter, carry the additional risk of acute pancreatitis. Triglyceride levels respond dramatically to dietary changes. Reduction in refined carbohydrates, sugar, and alcohol produces rapid and measurable improvements, often within weeks. I want to spend some time on LDL particle size, because it is one of the most clinically significant concepts in modern cardiology, and one that is almost entirely absent from public health messaging. LDL particles exist in a spectrum of sizes. At one end are large, buoyant LDL particles, sometimes called pattern A. At the other end are small, dense LDL particles, sometimes called pattern B. These two types of particles have dramatically different atherogenic potentials. Small, dense LDL particles are more dangerous for several reasons. They penetrate the arterial wall more easily than large particles because of their smaller size. Once inside the arterial wall, they are retained for longer. They have a higher affinity for the proteoglycans in the arterial wall that trap LDL. They are more susceptible to oxidation, and oxidized LDL is the form that triggers the inflammatory cascade, leading to foam cell formation and atherosclerotic plaque development. People with predominantly small dense LDL, LDL pattern B, have a threefold higher risk of coronary artery disease compared with those with predominantly large, buoyant LDL at the same LDL cholesterol level. The pattern of LDL particle size is strongly influenced by triglycerides and insulin resistance. People with high triglycerides, often driven by refined carbohydrate consumption, excess alcohol, and poor metabolic health, tend to have a higher proportion of small, dense LDL. This is one of the mechanisms through which the metabolic syndrome increases cardiovascular risk independently of LDL cholesterol. Improving insulin sensitivity, reducing refined carbohydrates, and losing visceral fat all shift the LDL particle distribution toward the less atherogenic, large, buoyant phenotype. Statins reduce both LDL cholesterol and LDL particle number, but dietary and lifestyle changes specifically target particle size in a way that medication alone does not. Statins may be the most debated medication in modern medicine. On one side, evidence that they represent one of the most effective cardiovascular risk reduction interventions ever developed, with a body of trial evidence spanning decades and millions of patients. On the other, a persistent, vocal, and largely evidence-free campaign claiming that statins are ineffective, dangerous, and the product of pharmaceutical industry corruption. I want to address both sides of this debate clearly and without ideology, because the stakes are genuinely high and the misinformation genuinely costs lives. Statins work by inhibiting the enzyme HMG-CoA reductase, which is the rate-limiting step in cholesterol synthesis in the liver. When the liver produces less cholesterol, it upregulates LDL receptors on its surface to absorb more LDL from the bloodstream. This reduces circulating LDL cholesterol and LDL particle number. Beyond their LDL lowering effect, statins have pleiotropic properties. They reduce vascular inflammation, stabilize atherosclerotic plaque, improve endothelial function, and reduce platelet aggregation. These effects occur independently of LDL reduction and contribute to their clinical benefit. The evidence for statins in secondary prevention in people who have already had a heart attack, stroke, or been diagnosed with coronary artery disease is overwhelming. High-intensity statin therapy in this population reduces major cardiovascular events by 25 to 35% and reduces all-cause mortality. For primary prevention, in people who have not yet had an event but who have elevated cardiovascular risk, the evidence is strong for people with a 10-year cardiovascular risk above 7.5 to 10%. The Cholesterol Treatment Trialist Collaboration, a meta-analysis of over 170,000 patients, confirmed a linear relationship between LDL reduction and cardiovascular event reduction across all risk groups. For every 1 millimole per liter reduction in LDL, major vascular events fall by 22%. The most commonly reported side effect of statins is muscle pain, myalgia, which occurs in approximately 5 to 10% of patients in observational studies, but in only 1 to 2% in randomized controlled trials, suggesting a significant nocebo effect, symptoms caused by the expectation of side effects rather than the medication itself. Serious muscle damage, rhabdomyolysis, is rare, occurring in approximately 1 in 10,000 patients. Statins are associated with a small increase in the risk of new-onset type 2 diabetes, approximately 1 extra case per 250 patients treated for 5 years. But this risk is substantially outweighed by the cardiovascular events prevented in high-risk populations. If you experience muscle pain on a statin, discuss it with your doctor. A change of dose or statin type resolves the problem in the majority of cases. Do not stop a statin without medical advice. For decades, the advice to reduce dietary cholesterol, primarily through limiting eggs, shellfish, and organ meats, was a cornerstone of cardiovascular dietary guidance. The science has now moved substantially. Dietary cholesterol has a modest and clinically limited effect on plasma LDL cholesterol in most people because the liver compensates for increased dietary cholesterol by reducing its own production. Large prospective studies have found no significant association between moderate egg consumption and cardiovascular events in the general population. The obsession with dietary cholesterol was, in retrospect, a scientific blind spot that distracted from the factors that matter more. The relationship between saturated fat and cardiovascular risk is more nuanced and more contested. The original hypothesis, that dietary saturated fat raises LDL cholesterol and thereby increases cardiovascular risk, is supported by extensive evidence for specific saturated fatty acids, particularly palmitic acid and myristic acid, which are found predominantly in processed meat, full-fat dairy, and tropical oils such as palm oil. However, not all saturated fats behave identically. Stearic acid, found in dark chocolate and some animal fats, does not raise LDL cholesterol. And the food matrix matters. Cheese, for example, despite its saturated fat content, is not associated with elevated cardiovascular risk in epidemiological studies in the way that processed meat is. The practical guidance is to replace saturated fat from processed and ultra-processed sources with unsaturated fat from olive oil, nuts, avocado, and oily fish. This substitution has a reliable and well-documented LDL lowering and cardiovascular risk-reducing effect. The dietary changes with the strongest and most consistent evidence for improving the lipid profile are replacing saturated fat from processed sources with monounsaturated and polyunsaturated fats, increasing soluble fiber from oats, legumes, fruits, and vegetables, which binds bile acids in the gut and forces the liver to use circulating LDL cholesterol to make more. Reducing refined carbohydrates and added sugar, which specifically targets triglycerides and drives the shift from small dense to large buoyant LDL. And following a Mediterranean dietary pattern, which in the Predimed trial reduced major cardiovascular events by 30% independent of LDL cholesterol changes. These 9 actions move the lipid markers that matter: ApoB, LDL particle number, triglycerides, Lp(a) where modifiable, and reduce cardiovascular risk through mechanisms that go beyond the standard cholesterol headline number. Replacing 5% of calorie intake from saturated fat with polyunsaturated fat, from oily fish, walnuts, flaxseed, and sunflower oil, reduces LDL cholesterol by approximately 10% and cardiovascular event risk by a clinically meaningful margin. The key distinction is source. The saturated fat in processed meat, biscuits, crisps, and palm oil-containing products has a different metabolic effect from the saturated fat in whole food dairy. Prioritize reducing ultra-processed saturated fat sources first. Increase olive oil, oily fish, nuts, and avocado as the primary fat sources in the diet. Soluble fiber, found in oats, barley, psyllium husk, lentils, chickpeas, apples, and pears, is one of the most consistently effective non-pharmacological LDL-lowering interventions available. The mechanism is direct. Soluble fiber binds bile acids in the small intestine, preventing their reabsorption. The liver must then synthesize new bile acids from circulating LDL cholesterol, reducing LDL levels. 10 grams of soluble fiber per day, achievable with a bowl of oats, a serving of lentils, and a piece of fruit, reduces LDL cholesterol by approximately 5%. It is not dramatic, but combined with other dietary changes, it is meaningful and it costs nothing. Refined carbohydrates and added sugars are the primary dietary drivers of elevated triglycerides and the small, dense LDL phenotype. Reducing white bread, white rice, pastries, sugary drinks, and ultra-processed snacks consistently lowers fasting triglycerides, often dramatically and within weeks. A reduction in fasting triglycerides from 3.0 to 1.5 millimoles per liter shifts the LDL particle distribution toward larger, less atherogenic particles without changing LDL cholesterol on the standard test. This is one of the clearest examples of why the standard lipid panel misses important clinical information. The improvement is real and significant, but invisible to the test most people receive. Regular aerobic exercise raises HDL cholesterol by 3 to 9%, the most reliable non-pharmacological HDL-raising intervention available. It also lowers triglycerides by 10 to 20% with consistent practice, and reduces LDL particle number independent of LDL cholesterol changes. Resistance training specifically reduces small, dense LDL particle number and improves insulin sensitivity, which indirectly shifts LDL particle distribution toward the less atherogenic phenotype. The combination of aerobic and resistance training produces better lipid outcomes than either alone. Visceral fat is the primary driver of the atherogenic dyslipidemia pattern: high triglycerides, low HDL, and elevated small dense LDL that characterizes metabolic syndrome. Losing 5 to 10% of body weight, particularly from the abdominal region, produces significant improvements in all 3 components of this pattern. The mechanism involves reduced hepatic fat, improved insulin sensitivity, and decreased free fatty acid flux to the liver, all of which reduce VLDL production and the downstream formation of small, dense LDL. Waist circumference reduction is a better predictor of lipid improvement than scale weight. Alcohol has a significant and dose-dependent effect on triglycerides. Even moderate alcohol consumption, 2 to 3 standard drinks per day, can substantially elevate fasting triglycerides in susceptible individuals. Heavy alcohol use is one of the most common causes of severely elevated triglycerides and hypertriglyceridemia-induced pancreatitis. Reducing alcohol is frequently the single most effective intervention for lowering triglycerides, producing reductions of 30 to 50% within weeks in people who drink regularly. If your triglycerides are elevated and you drink alcohol, reducing intake should be the first intervention before any medication is considered. This is the most important practical action in this entire video. At your next blood test, ask your doctor to add apolipoprotein B and lipoprotein A to your standard lipid panel. ApoB gives you the particle count that LDL cholesterol misses, the true measure of atherogenic burden. LPA gives you the genetically determined risk factor that is present in 1 in 5 people and that standard tests never measure. Both are available on standard laboratory platforms in most healthcare systems. Both change the risk conversation. You will not get this information unless you ask for it by name. If your 10-year cardiovascular risk is above 7.5 to 10%, calculated using tools such as QRisk3 in the UK or the pooled cohort equations in the US, statin therapy has a well-established benefit that exceeds its risks in the evidence base. If you have already had a cardiovascular event, high-intensity statin therapy is standard of care with strong mortality benefit. The misinformation around statins is extensive and has been responsible for significant preventable harm through medication discontinuation. If you have concerns about statins, discuss them with your doctor, but do so in the context of your actual cardiovascular risk, not the anecdotes circulating online. For people who cannot reach their LDL or ApoB target on maximum tolerated statin therapy, either due to side effects or inadequate response, additional options are now available with strong evidence. Ezetimibe, which reduces cholesterol absorption in the gut, lowers LDL by an additional 15 to 20% with an excellent safety profile. PCSK9 inhibitors, injectable monoclonal antibodies given every 2 to 4 weeks, reduce LDL by 50 to 60% on top of statin therapy and have demonstrated cardiovascular event reduction in large trials. For people with familial hypercholesterolemia, a genetic condition causing extremely high LDL from birth, early and aggressive treatment is essential, and these additional therapies are frequently necessary. If you have an LDL above 5 millimoles per liter or a strong family history of premature cardiovascular disease, discuss familial hypercholesterolemia screening with your doctor. I want to end this video with a clear summary of the most important thing I have said today. The number most people use to assess their cholesterol risk, total cholesterol, is the least useful number on their lipid test. The numbers that matter are LDL cholesterol as a starting point, but more importantly, ApoB, which counts the atherogenic particles, Lp(a), which reveals the genetically determined risk that 1 in 5 people carry without knowing it, and triglycerides, which reflect metabolic health and the shift to the more dangerous, small, dense LDL phenotype. If you know those 4 numbers and you understand what they mean, you have a genuinely accurate picture of your cardiovascular lipid risk. If you only know your total cholesterol, you have a headline without a story. 7 videos into this series, liver, blood pressure, kidneys, diabetes, heart disease, stroke, and now cholesterol, I hope you are beginning to see the connections between these conditions as clearly as I do in clinical practice. They are not separate problems. They are expressions of the same underlying vascular aging process, driven by the same modifiable risk factors and protected against by many of the same interventions. That is the framework that makes prevention powerful, not managing each condition in isolation, but understanding the system. If this video helped you understand something that your lipid test has never explained, please share it. With someone who has been told their cholesterol is fine and has never heard of ApoB. With someone who has been refusing a statin based on social media advice. With someone whose triglycerides have been high for years and who has never connected it to their refined carbohydrate intake. Subscribe so you do not miss video 8, where I will be covering fatty liver disease, the condition now affecting 1 in 3 adults globally that produces no symptoms until it is serious, and that most people have never connected to their metabolic health. I will see you there.